Chairman, thank you so much for hosting this hearing. My first question is for Professor Fiedler, probably, my bad, Fiedler, right? Okay. Prior authorization is the #1 administrative concern to physicians. It adds to their burden of their day, having a patient scheduled for a hip replacement, having them in the preoperative area, and then finding out that the insurance company has not done the final prior authorization for that particular process. I'm assuming you're familiar with prior authorization and how it's being used to ration care. What is the prior authorization impact, do you think, on healthcare expenses? Does it actually slow down? Does it make it worse? Any thoughts on prior authorization?
So I think prior authorization is very much a two-edged sword. On the one hand, I think exactly what you're talking about, it can create a lot of administrative hassle, both for providers, but frankly for patients as well, right? If you're the patient in that situation where the prior authorization hasn't come through, that's a very real burden. I think the flip side of this is there are cases where prior authorization is used appropriately, and we have evidence that it meaningfully reduces use of inappropriate services and therefore reduces claim spending and premiums and cost sharing for patients.
Appreciate that. I think you'd agree with me that if there was a streamlined, consistent process, that would be very beneficial to both sides of that coin.
I think there likely are opportunities to streamline these processes, and that's a fruitful place to explore.
Okay, I'm going to go to Mr. Merkel next, and kind of following up with Senator Braun's questions regarding the physician-owned hospitals. I may be the only person in the Senate, Congress, that's ran a hospital, owned a hospital, a private practice, oversaw health departments. I understand healthcare, pretty good. I always thought to write down the cost of healthcare, we needed more transparency, more innovation, and consumerism, making patients consumers again, promoting competition. Whether it's insurance companies or whether it's hospitals, PBMs, we've seen this huge consolidation of the industry, partially because of overregulations. And basically there is a moratorium on physicians to expand their hospitals or to have any new ones as well. I would brag on the physician-owned hospital. They have better care, much better quality of care. They actually give away more care than most nonprofits do as a sense as well. In our particular case, we were the only hospital within 60 miles with a level 2 emergency room. So we took all comers. So, Mr. Merkel, what was your experience with physician-owned hospitals, and do you think that they would help drive the cost down or up at the end of the day?
Thank you for your question, Doctor. I think that, with fee-for-service reimbursement and our entitlement programs being basically unlimited in how much taxpayer money that they will provide, Congress over the years has tied themselves into a lot of knots on how to try to protect taxpayers while in that system. And industry incumbents take advantage of those concerns and will utilize those fears to try to block competition from things like physician-owned hospitals or through certificate of need laws. I think both of those restrictions come from the same concern and demonstrate how industry incumbents basically use them to prevent competition.
Great. I'm going to finish up with the question, how much time we left. We'll see if we get through as many people as we can. We'll start with you, Dr. Daphne. I'm certainly a believer that our country needs a bigger investment in primary care. Everybody, if you have a heart attack, if you're in an automobile accident, you go to the emergency room, you're going to be taken care of, but we don't have as much meaningful access to quality primary care. Maybe we're spending half as a percentage of investment that many other countries are. Dr. Daphne, what do you think the impact of more primary care would do on the overall cost of health care, the overall expenses of health care?
Thank you for the question, Senator Marshall. I would say that relative to other countries, we spend far less on primary care than they do. And that results in pushing more spending to specialists whom we know are more expensive. I think it would be a tremendously valuable thing. We ought to look at the compensation for primary care specialists relative to specialists and to encourage more entry into that field, and would defer to the primary care physician to my left, should you want.
Dr. Croce, please go ahead. It's okay.
I concur with all that, and I think that particularly given the complexity and fragmented nature of our healthcare delivery system writ large, it's never been more important for patients, particularly with complex or chronic illnesses, to have a primary care physician that can help guide them through that system, make decisions, coordinate everything, and have them stay on top of things. And you know, to me, that's foundational for a high-performing healthcare system of any kind.
Yeah, great. Certainly, I concur that in an instance, we're certainly thinking that community health centers are a big part of that, an opportunity where you can deliver health care to where the patients are, adding mental health support right there, nutrition coaching, those types of things. And since there's no one else standing in line, Dr. White, what do you think about more primary care, how that would impact the cost of health care for this country?
We have spoken to a number of experts about alternative payment models and ACOs, and they have pointed out that primary care is really central to ACOs in a very kind of nuts and bolts sense. To get patients attributed to an ACO, they have to be receiving primary care services. So that's kind of foundational. But there's also this phenomenon that physician-led ACOs are clearly more successful on reducing spending than hospital-led ACOs. And
imagine that.
And what we've gathered is that the physician-led ACOs tend to focus on shifting care away from facility settings, specialty care, imaging services, and so I think that's generally consistent with what you're saying.
Yeah. Thank you, Chairman. I yield back.
Thank you. Senator, while you were in your other hearing, we also had a bit of a conversation about prior authorization, and Dr. Kouros, and I think with other heads nodding, made the point that when you're in a fee-for-service system, there is some rationale to prior authorization to prevent just piling on with the billings. But once you move to a value-based system, like accountable care organizations run, then the logic, the rationale for having prior authorization diminishes, if not evaporates. So I appreciated your questions about prior authorization. I wanted to fill you in on what the prior testimony had been, and I do think that there's room as we move towards more value-based care in our healthcare system to make sure that the bureaucracies keep up with that, and you're not running legacy prior authorization systems that require doctors to maintain administrative staff that serve actually no real purpose, because you've reoriented the incentives so that it really doesn't make sense to require prior authorization. Maybe there should be prior approvals for prior approvals.
We used to have that. So I certainly agree and concur that we need to go to these value-based models, and it would eliminate some of the need. But in the meantime, 90% of the healthcare system is going to fight that. And it'll take years to see that happening, and I think it's all the more important that we lean in as some type of a streamlined fix to the prior authorization issues, rather than punishing the 98% of physicians that are doing the right thing, and focus on those folks that who are indeed are abusing the system. So thank you. I appreciate those comments.
And I'm now delighted to recognize Chairman Wyden, who has stepped out of the Finance Committee briefly to join us. Thank you, sir.
I thank my colleague, and this is a very good hearing.